I will talk about the sites of action of antidepressants. I will mention once more that, of course, we need to treat the brain, different parts of the brain. The mechanism of actions have been already excellently explained before. I will talk a little bit about a new theory which gets more and more attention, is the neuroinflammatory theory of depression, and then I will present my view from the available data of trazodone slow-release formulation. Let me start also with my conflict of interest, which are nowadays shown in all of these meetings, including pharmaceutical companies and also non-pharmaceutical industry. Let me remind you what I mentioned already in my presentation this morning, that there are some key areas which are treated with the antidepressants from a structural point of view. We treat the amygdala and also the hippocampus as one of the main structures, and this is nowadays a topic of research in several centers. Like in our center, when we give antidepressants compared to placebo, you see the difference from the whole brain where the action is from the antidepressant to the placebo is the amygdala. As I mentioned before, the raphe nuclei, for instance, would be very interesting also to get, but unfortunately the solution of our machines is not good enough as yet. Hippocampus, another very important area, would like to remind you once more that we need to treat our patients aggressively, otherwise there is a reduction in the hippocampal volume, as shown in this publication, when they took the days of untreated depression and the hippocampal volume. You see the hippocampal volume gets lower with the longer duration the patients are untreated. So when we go on a molecular level, then you see there are several synapses, and these synapses are influenced by different mechanisms, and in the depressive state you have less of these synapses, and the synapses get less with the increase of glucocorticoids, and also the brain-derived neurotropic factors play an important role, and the monoamines play a role. When you have lower monoamines, then you have less of these synapses. We heard the role of glutamate. So by treating our patients, we have to restore this underlying disturbance, and luckily enough, those are the data from animal research. In a number of patients, this is possible to change the state from here to here, and therefore we need to aggressively treat our patients also with modern approaches. So this has been also put in a cartoon by Steve Stahl, who merits to make all these difficult mechanisms more easy. So he depicts here that glucocorticoids, stress, and glutamate are responsible, that there are no brain-derived neurotropic factor. On the other hand, if these clouds are gone, then there is a cell sprouting, and some people could say like this is like a fertilizer for the brain. Well, it's not a fertilizer, but definitely it's very important that we have brain-derived neurotropic factor available for our patients. This slide you saw in a different matter already from our previous speaker. It has the same substances, and it reminds me that in the mid-70s, when I started my psychiatric training, trazodone was already around. As a matter of fact, it was one of my first publications in 1978-79, when we compared it to amitriptyline, and we could find out that the side effect profile is much better than with the tricyclic. And you might be reminded also that trazodone was the leading antidepressant before the introduction of the SSRI in the United States, because the United States, they did not have a serotonergic antidepressant before, because interestingly, clomipramine, anafranil, did never have the indication for depression. They had the indication for OCD, but not for depression in the United States. So trazodone was actually number one, but the doctors tended to forget it. When all the SSRIs came into the market, then the share of the trazodone went down. But importantly, in these days, we didn't have any idea how this medication was working, and with the newer mechanism of action understanding, we now sort of rediscover over here the mechanism of trazodone and relate it also more to clinical issues. So trazodone is an old medication, let's put it this way, but it's now newly understood with a newer mechanism of action, and we have now not only the immediate release formulation available, but also the prolonged release formulation, which allows to give the medication 2 times a day. But I would tell you frankly, we use it very often also as a once-day medication compared to the trazodone immediate release formulation, where you give the medication like when the patient wants to sleep at 10 o'clock, you ask him to take it at 9:45. But with the slow release formulation, you need to ask them to take it earlier, because you have a gradual increase of the substance, or not a peak, but the immediate release formulation. So before I go to the different mechanisms of action, I would like to remind you, with the SSRIs, we learned that there is the serotonin reuptake pump, which is lower of activity in our depressed patients. We do not know that much about the norepinephrine reuptake pump, which of course is also lower activated in our patients. And with the SSRIs and the SNRIs, we block these receptors, these transporters, in order to have a higher activity in the synaptic cleft. As easy as this looks, as life is of course not as easy. And when I show you the serotonergic synapse, then you see the serotonergic pump, the transporter. Over here, you see the 5-HT1A receptor, you see the 5-HT2A, 2C receptor. Altogether, there are at least 14 of these serotonin receptors, but it looks like the 5-HT1A and the 5-HT2A and 2C are probably the most important right now, and I would like to continue a little bit about this. Nowadays, we are lucky enough, we can map the different transporters, like over here is the serotonin transporter, is in the RAFA nuclei, and then the serotonin 1A receptor in cortical parts. Pretty much the same distribution you would get with the 5-HT2A receptor, and we know this, for instance, also from the atypical antipsychotics. So let me remind you once more, the cell bodies of the serotonergic neurons are located in the midbrain. The axons project to all different brain areas, a number of different receptors. All of them are postsynaptic. 5-HT1A and 1B are also presynaptic, and you are reminded to the pindolol story, that pindolol, one of the beta blockers, they block the 5-HT1A autoreceptor and therefore increase the serotonergic output. It looks like 5-HT1A and 2A are the major receptors, and the SSRIs work by blocking the 5-HT2 reuptake and increasing the serotonergic transmission. So just to remind you once more, on this slide, it's indicated that the 5-HT1A and 5-HT2A receptors, they are co-expressed at the same time, and you find them also on the pyramidal cells in the cortical areas. So this indicates also to us, when the patients say, well, I can think more clearly, this is related to these cortical areas. Of course, all of these areas, they have a feedback mechanism to different other structures of the limbic system. To continue a little bit further, I would like to emphasize to you there is now a days again, I would say, it was discussed 20 years ago, but now again a cytokine hypothesis of the depression because it's well known that pro-inflammatory cytokines, such as IL-1, IL-6, TNF-alpha, they are able to induce symptoms of depression and major depression in patients who did not have a history of mental disorders before. And therefore, there has been a link together with depression. And so the cytokines and the neurotransmitter system seem to have an intermediate role between depression on the one hand side and inflammation and pain on the other side. So when you look at the different immunological parameters in depression, I would like to remind you that you have a number of substances increased in depression in the acute phase. You see also that the lymphocytes in the blood go up, the mononuclear cells go up. So this is a long, well-known situation. And when the cytokines are used therapeutically, then you have, like in about 1/3 to 1/4 of the patients, you have depression, and the doctors usually, like on oncology departments, they add already beforehand antidepressants, or they ask a psychiatrist for a judgment in order to prevent depression in these cases. Of course, therapy interruption is not always possible when you have to treat the serious illness. Here is a depression treatment, is a development of depression in cancer patients under cytokine treatment. You see the Montgomery-Åsberg rating scale on day 1, day 3, and day 5 with different compounds, IL-2 plus interferon, or interferon intravenously. You see the IL-2, and with subsequent days you get higher values of depression. And when you treat these patients, then the IL status goes down. So here is the change of IL-6 with treatment in major depression compared to controls. In depression, you have higher values, and treated with antidepressants, then this goes back to the normal value. Another issue is about also which patients respond and which do not respond to the treatment. You have here the responders. Here you have the higher values of IL-6 in depression compared to controls, like you have here. But you see in non-responders, the response is not statistically significant. In this case, amitriptyline was given, one of the tricyclic antidepressants. So when you look in the in vitro effects in animal research, you can see that SSRIs, tricyclic, but also the SARI, the trazodone, they affect these immunological parameters like interferon or IL-10 or the ratio of IFN and interleukin. So you see the trazodone is in the area of the other antidepressants to influence also the immunological system. So a quite important issue how not only the neurotransmitters work together, and one issue that depression can be viewed as a systemic disorder which affects different neurotransmitters but also immunological parameters. The 5-HT2 antagonist ketanserin, which is used for experimental reasons, or methylthepine, is an unspecific 5-HT antagonist, also reduces the T lymphocytes from peripheral blood in humans. So when you have this picture, depression on the one hand side, on the other side, pain, inflammation, and I did not talk about insomnia, but we heard before already the role of antidepressants on insomnia. So that seems to be clinical, very important areas to further also stress on. I will talk in the future, in the next part of my presentation, about the role of trazodone to depression and also insomnia, and compare it to different other available antidepressants. You saw this cartoon already before. It's pretty much the same, only that the 5-HT2 receptor is not divided in 2A and 2C. But quite importantly, I would like to stress once more, you have the antihistaminergic properties, which induces a rapid sleep onset. Unfortunately, might also be related to some overhang on the next day. Then the serotonin reuptake blockade, which results in a higher serotonin amount in the serotonin cleft, and the 5-HT2. So you might say, well, where is the 5-HT1A? It has been explained to you before already, and I would like to mention once more, this is an indirect effect of the 5-HT1A, because only a 5-HT1A agonistic property is not enough. Like all of you used buspirone, or you use buspirone, but it's not a strong medication for anxiolytic properties. It's like an add-on medication. So together with the antagonistic property of the 5-HT2A and the serotonin reuptake blockade, you have a very strong also signal at the synaptic cleft. However, you have to go to higher dosages, 300 or 450 milligram, in order to have also enough output from serotonin via the serotonin transporter. This cartoon you saw already, but I think it's very interesting to view once more. There's the serotonin transporter on the one hand side, and on the other hand side, I think it's the serotonin. Oops, no, it's completely gone. No, it's better. The serotonin 5-HT2, I think it's now better, yes, it was too high up. The 5-HT2A, when you block this receptor, then you leave more activities out for the 5-HT1A receptor. So this is a direct blocking effect, which has some anxiolytic properties, and the indirect effect via the 5-HT1A has additionally antidepressant efficacy. This is displayed here by the Ka values, the 5-HT2A, alpha 1, there is no antimuscarinergic, no norepinephrine reuptake inhibition. There is some serotonin reuptake inhibition, dose dependent. In lower dosage you have a lower blockade. In higher dosages it reaches the dosage of the SSRIs. So what doctors usually do, they add trazodone to an SSRI. So you could do this, but on the other hand, you could also raise the level of trazodone to 300, 450 milligram. Then you have the same efficacy because you have a higher serotonin transporter activity, and you have the antihistaminergic property, which gives the patient usually a rapid sleep onset. Here is the one study which has been already shown before. It was one of the first study on the trazodone prolonged release formulation comparing to paroxetine, and you see here two measurements, one with the Hamilton Depression Score and one with the MADRS score. One might ask, why did I use two scores? It's important. The Hamilton Depression Score has 3 items for sleep, like early sleep onset, then to prolonged sleep, and then early awakening, and this has only one sleep item. So naturally a medication which induces sleep gives better values compared to those who do not induce sleep. So one might say, well, it's an unfair comparison if you compare trazodone to paroxetine with the Hamilton score. Therefore we used also the MADRS score, and you see equal efficacy from both of them. I do not want to show you the side effect profile. The side effect profile was significantly better for trazodone, specifically on the items of sleep. It improved sleep where it was not improving sleep, and it made it even worse in paroxetine. No nausea because there was no active stimulation of the 5-HT3 receptor, and also no sexual dysfunction. That would be the major difference on a side effect level. With regard to remission, it was the same. I mentioned this study. It is important insofar because sometimes it is thought that trazodone is only a weak antidepressant compared to the SSRIs. Well, if you leave it in lower dosages, 75 to 150 milligram, it's a weak antidepressant, but you need to go up to 300 milligram, then you have the full antidepressant property. As it was done in this study, you see it's not distinguishable to paroxetine. Sertraline, another medication which was mentioned before already, is also an SSRI, as you know, and then the dosage was also 150 to 400 milligram in the prolonged release formulation. And with regard to responders and remission, there was a numerical advantage of trazodone. However, it was not statistically significant difference, and in both measurements, in the Hamilton score and the MADRS score, was the same effect. The last part of my talk, I would like to talk also about the sleep-inducing properties of the antidepressants, and you have different ones like the tricyclics, the SSRIs, then the norepinephrine reuptake inhibition, then the MAO inhibitor and the 5-HT2 antagonists. And you see some of them, they improve the slow wave sleep, like amitriptyline. Most of them, like the SSRI, they severely reduce the slow wave sleep. And you know, slow wave sleep is the major component for sleep architecture for a good sleep. And trazodone and mianserin, they increase the slow wave sleep. And this goes along also with sleep continuity. You have higher rates here, and then you have lower rates for the SSRIs here. So what is done in clinical practice very often, that SSRIs are combined with trazodone, but I said before, if you raise the dosage of trazodone, then you do not have to do this. So trazodone, on the other hand, and I will show you the data, this is just a cartoon to sum up, altogether increases the sleep period, increases the slow wave sleep, and also increases the REM latency, which is shorter, usually in depression, and there's still a question mark on the propensity of REM sleep. So the major components are cured, and this is one of the publications for total sleep time in trazodone, 400 to 600 milligram. You see the total sleep time dramatically increases with the initial treatment and also then the long-term treatment. And when you look at about the different periods, like comparing to the control period, the initial period, and the terminal period, you see that the number of awakenings, the total duration of awakenings goes down, and a significant advantage of trazodone, which you probably know when you use this medication in your daily practice. Sleep latency also is cured with trazodone, and you see here the minutes of sleep latency in the control period, in the initial period, and in the period of the end of this trial. Then you see that is significantly already cured at the beginning and then constantly throughout the last period. The effect of REM latency. In the REM latency gets shorter in depression, and you see here in the control period it goes down to 50, 60 seconds and minutes, and then you see in the initial period it goes up, and in the terminal period of this study then which was like 28 days, you have the increase of the REM latency, which is connected also to the antidepressant efficacy. In our department, in the sleep laboratory of my department, Dr. Saleto Zülatz did a number of studies comparing trazodone and placebo, and the main finding also in this group of thoroughly examined patients is the increase of the total sleep time and the total sleep period. You see the REM latency was changed, and also different other parameters were changed towards the right direction. Another study looking at the Pittsburgh Sleep Quality Index, and you see here this diamond-shaped indications. They show the baseline, and here this rectangular, they show then at the end of the treatment, you see the global Pittsburgh Sleep Quality Index gets to lower values, which means a positive outcome in these patients with suffering from insomnia. Depression is also linked to anxiety disorders to a large extent, and therefore it's quite important that there is a high comorbidity from 40 to 60%, and there seems to be a continuum, not always that the patients, they have the full-blown other disease like panic disorder, social anxiety disorders, or general anxiety disorder, huge overlapping features. So for an antidepressant to have also anxiolytic properties seems to be quite important. To summarize the mechanism of action of trazodone, it can be mentioned that it has antidepressant activity, anxiolytic activity, effects on sleep disturbances, and I did not talk today on the effects of agitation, which comes via the alpha-1 antagonism and is specifically also helpful for elderly patients. Would like to remind you once more that the antidepressant activity comes via the 5-HT1, the 5-HT reuptake inhibition, and the blockade of the 5-HT2 antagonism, which both goes to an indirect agonism of the 5-HT1A receptor, which is responsible for the antidepressant activity. The anxiolytic effect comes via the 5-HT2 antagonism as well as the 5-HT2C antagonism, and the sleep-inducing effect come from these three components: the antihistaminergic, which gives the rapid induction of sleep, alpha-1 antagonism, alpha-5-HT2 antagonism. So although trazodone is a very old medication, over like 30 years already under research and on the market in a number of countries, nowadays with the new technique we understand it better, and we can relate it to the different clinical, also meaningful parameters. Steve Stahl mentioned one on his paper, and I think it is quite important to remember that we are living nowadays in the time of polypharmacy, meaning that more medication are given to our patients. Like, for instance, we give SSRIs, and then we think, well, probably an NRI, a norepinephrine reuptake inhibitor, would help him, so we have then a polypharmacy with different medication. Here I showed you different mechanisms of action, like the 5-HT1A antagonism, serotonin reuptake inhibition. So this medication can also be termed as an intramolecular polypharmacy, but in a good sense, that you have mechanisms of action which can be linked to the therapeutic mechanism of action, like tricyclic antidepressants also have this intramolecular polypharmacy, but unfortunately with the anticholinergic properties which you do not really need. With this, I thank you very much for your attention, and I'm looking forward for some questions.